Next, we have an insightful panel. I'd like to introduce Paul Cohen, VP of Strategy at One Medical, Colin Hill, Chairman, CEO, and co-founder of GNS Healthcare, David Giannetti, President, Clinical Technologies at Astarte Medical, Ann Mon Johnson, CEO of American Telemedicine Association, Justin Barad, co-founder and CEO of OssoVR, and joining them on stage today is my colleague Julia Manchester, a staff writer for The Hill.
Companies you bring to the, oh, there we go. Tell me about your companies and what they bring to the healthcare world and how do they move healthcare forward in this country. Justin, let's start with you.
Sure thing. So OssoVR is a global surgical training platform that leverages virtual reality. Our mission is to improve patient outcomes, increase the adoption of higher value medical technologies like robotics, and democratize education to surgical education all around the world. I don't want to get real deep into it, but we're in the midst of a surgical training crisis, both here and abroad. Studies have shown in 2017 that 30.7% of our surgical residency graduates, this is after 4 years of medical school, 5 years of residency, and 4 years of college, are unable to operate. So just keep that in mind. And at the same time, we are never assessed for our surgical skill at any point during our training. And when you look globally, something around $12.7 trillion of economic productivity are lost due to inadequate access to quality surgical care, mainly related to training. So OssoVR leverages virtual reality to improve surgical skill by 230% in a study that was performed by UCLA, and we're training around 10,000 surgeons a year currently.
Great, Ann, let's go to you next. In the meantime, let's go to David. We
Okay.
can definitely come back to you once we hear you.
Am I on? No.
Oh, let's see.
Okay. I can just talk loud.
Okay, yep, that works.
So Astarte Medical is a precision healthcare technology company focused on premature infants and nutrition. We have found that there is very strong clinical data that following a feeding protocol, regardless of what that protocol is, has better outcomes for premature infants. So we're able to currently survive babies that are born at 22 weeks gestational age, so literally half-term pregnancies. And what we are doing at Astarte is using big data to come up with a better feeding protocol to allow those babies to thrive and grow. And so we are focused on the first 1,000 days, which is really conception until about age 2. We have built about a 30 terabyte database of microbiome sequencing data. So we're combining the microbiome information with the clinical data from the EMR, and we're creating solutions that are going to help clinicians feed our babies and get them to grow.
Ann, do we want to try your mic again?
Let's try this.
There we go.
Good. Good morning. Ann Mon Johnson, CEO of the ATA, the American Telemedicine Association, and we are the longest standing organization of delivery systems, payers, vendors, solution providers, academic medical centers that are all focused on the dissemination of telemedicine and really to make telemedicine medicine, telehealth health. I would say that our focus as an organization is to ensure that people get care where and when they need it, and that when they do, they know it's safe, effective, and appropriate, and that clinicians are able to do more good for more people. While technology has been available for over 25 years, the reality is that uptake is very low. Only 20% of consumers use telemedicine of any kind, and only about 15% of physicians do. So our focus now as an organization is to ensure that we put in place the tools, the resources to accelerate the adoption and engagement in telehealth by both consumers and providers, and to make sure that we are changing the story so people understand how important and how useful technology can be, because as was acknowledged before, we don't have enough resources, we don't have enough clinicians, we have to continue to train and make them available. And so this technology could be used to really make all of that happen. And then we can talk about the Mueller report. So.
Okay, Colin, you next.
Sure. So patients often don't receive the right treatment the first time. No one's an average patient. So we believe it is possible, with all of the data exhaust generated from all of the treatments that patients receive across many diseases, it's now possible to turn that data with the use of specialized AI, causal AI, and machine learning into in silico patients, computational representations of patients, such that we can simulate treatments in patients ahead of time so that patients are not treated like guinea pigs. So what does this mean? It means running clinical trials in silico. Just like Airbus or Boeing simulates planes under many different conditions of wind shear, of different designs, different temperatures before a prototype is even built and tested in a wind tunnel, we can and need to do the same in the medical industry. And we are at a stage, after many cycles of innovation, from the sequencing of the human genome, so now we have molecular data at a large enough scale, together with electronic health record data and other clinical data, to now do this. And it's no longer theoretical. Our company has now been at this for almost 20 years, and along with others and an ecosystem of other innovators, we have now crossed into a time where the computer models of patients are starting to become more and more accurate, and we do have pathways, even within the government, such as 21st Century Cures, that will soon start to allow real-world evidence coming from these in silico patients to drive both just drug development as well as patient care, improving outcomes, and lowering the total cost of care.
Thank you. And Paul, why don't you just round us all out?
Raise your hand if you're familiar with One Medical. Two are a little bit less familiar. One Medical is now the largest independent primary care delivery system in the country. So we use a membership-based model which pairs with your existing insurance to provide high access to high quality and affordable primary care. We do that by employing top-tier primary care providers in really convenient locations across the country, and patients are able to get in quickly. And so we're famous for same-day and next-day appointments that start on time and last longer. Our average appointment is over 30 minutes long, and that's pretty hard to find in 2019. So we pair that in-office model with intelligent use of technology. And what that looks like is patients can contact their care team via video, via chat, via secure message, structured triage. They can do that in the app. They can do it on a landline. They can do that on the web. They can do it any day of the week as much as they want as part of their membership. So we serve consumers directly across the country. We also partner with over 3,500 employers, hospital systems, and health plans to provide national access to One Medical.
And I was looking at a study that really caught my eye, and it was from 2016 to 2017. It said that telehealth insurance claims filed during that period of time went up 53%. So clearly, telemedicine is really exploding in the U.S. And from a journalist perspective, you hear a lot about the rural divide in telemedicine. But we were talking before, and you mentioned a lot the urban divide as well. So can you speak to that urban divide as well as the rural divide and how telemedicine is looking to bridge it?
Sure. So the reality is that when you talk about telemedicine, historically it's been in the context of how it can be used in a rural community. And there's certainly a lot of healthcare challenges in those communities. Hospitals are closing at a rapid rate. There are inadequate resources. The few physicians that would practice in a particular county, for example, go through burnout because they are the last person standing often. And so the technology through systems like Avera in South Dakota or others like the Mayo in northern Minnesota and Wisconsin, what they're doing is really availing technology and support so that really great medicine and healthcare can take place regardless of where you are. But if you think about it, there are a number of individuals, even in a community like here in DC, where it takes 2 hours to go from point A to point B. You have to take your child to the physician to see them before you decide whether or not you're going to go to work. And that's just an untenable situation for many of us. And so what we're increasingly facing is that consumers have their expectations shaped by what happens to them outside of healthcare, and they're bringing those expectations to healthcare. So the notion of convenience and access and I want what I need right now is very much happening in an urban environment as well.
And Justin, let's talk about the advances you've been working at, also VR, in terms of surgical training and such. I guess what can advances in this area mean for the entire healthcare system?
It's really, there are a few things. One, it's an issue of access and equality. So very similar to the issues you were describing. Right now, there are surgeons here in DC who are operating on hundreds, if not thousands of patients a year, and they know what they're doing a great job. Now you go to a rural area and maybe they're doing those surgeries 4 or 5 times in a year. So just intuitively, and the data supports this, those outcomes are not going to be as good as the surgeons that are doing it multiple times a day. And so patients in these remote areas, and this also applies for low and middle income countries, are not getting the same quality of care. Now, if these surgeons are able to practice these surgeries not on patients, very similar, in a simulation, then they can assess themselves, get back up to speed, and make sure they're operating at peak capacity. And another issue of access is one of technology, much as expectations are changing in our patient population. So I'm a physician, I have patients coming to me, they'll have, and not even a printout anymore, but they'll have their phone and they'll have something loaded up ready to go, and they say, I want this surgery. And often it's some fancy technology with robotics, maybe a laser, and I've never seen this device or used it before. And the process of learning to use these devices is quite cumbersome. What I'll have to do is I have to be flown out by the company like Johnson & Johnson or Stryker to a hotel ballroom. By the way, everybody should read this article, Reuters, Cadavers in the Ballroom. It's very interesting how these trainings happen and often how close in proximity they are to some big events like bar mitzvahs and weddings. But just they cover the ground really well with TARP. But you only get to practice 1 or 2 times, and that's not nearly enough. The data shows that to learn a new robotic system or advanced medical technology, you have to do it 50 to 100 times. So what our technology and technologies like it allow you to do is practice 50 to 100 times until you reach proficiency, so that you can rapidly learn to use these new technologies that not only patients want, but brings them more value and decreases cost to the system.
And so we're seeing that equality and access seems to be a bit of an overarching theme in this conversation. So David, in your work in infant care and such, can you explain how that theme is really playing into your everyday work there?
Yeah, so I think when we're talking about our patient population, we are almost exclusively looking at the level 3, level 4 NICUs. So these are centers of quality by definition. And what we are really looking at is the liberation of that medical record data so that we can predict the pathway for gut information, right? So we're actually consuming this information, we're building our models based on machine learning, and so what we have been struggling with is actually to just liberate it, and we use that word, liberate the data, right? Because it is, in some respects, held hostage by some of the electronic medical record systems today. And so, I think quality of access maybe doesn't apply for our population, because we are very critical preemies that we're helping. But I think providing access to that information and letting us use that data to better serve this population and create a better health plan for them going forward, and then follow them home, is really what we've been focused on.
Right. And Paul, basically the same question for you. How does this apply to primary care? Because it seems that, in what I've read, there does seem to be a bit of a divide in your field of work there.
Yeah, so what's happening right now in primary care is a national conversation about the role of primary care, right? And what we're seeing is that folks are upset. Everyone knows the current healthcare system, it's not serving consumers, it's not serving employers, it's not serving the providers who are rendering care. And we've seen a failure of the incumbents to kind of change the care delivery system to meet the needs of a changing American population. And so that's why One Medical exists. When we look at what's happening, though, there's a couple of things that give us excitement and give us promise. And it's really around this theme of integration. How do we integrate care? We see the future of integration relating to bringing behavioral health into primary care, right? Part of health equity is actually having your mental health and your physical health unified. And we do that at One Medical by having highly trained PCPs who are able to not just manage psych meds, but also manage lifestyle interventions. We use board-certified health coaches to help patients change their own behaviors. And we have group visit programs for stress and anxiety and insomnia and depression, which are very popular in downtown DC. So this mental health integration is a really key theme. Another big source of integration is integration with the healthcare system, right? An element to health equity is having your PCP have access to your specialist records, knowing when you get admitted to the hospital, and knowing when you get a flu shot at a Walgreens, right? And having that all be integrated. It's hard work, and you have to invest in it, but it's a key part of healthcare going forward. The last comment I'd make on that thread is integration of in-person and virtual. We're really excited about virtual care, but we're worried about the impact it has when care gets fragmented. One of the things that makes One Medical so powerful is the fact that when you call us at 2 o'clock in the morning trying to decide whether to go to the ER or whether to tough it out at home, you're talking to a One Medical provider who's trained well, who has access to your records, who knows your PCP, and is part of our system. And so as a result of that, we see utilization of virtual care that is 10 to 15 times higher the industry benchmarks, right? So in our mind, the future of primary care is integrated. And if we can do that, the good news is that we can make healthcare more equitable by reducing the cost of care. We've shown at One Medical that by incorporating all of these elements, we reduce the total cost of care 5 to 10% on commercially insured populations while delivering quality scores in the top 10% of the nation. That's what we're doing at One Medical, and that's where primary care is headed.
Now, before I jump back to Colin, I just want to remind the audience that we will have a few minutes for a Q&A, so start thinking of those questions. And Colin, tell me about your work in precision medicine. I was reading your bio, and obviously you've done quite a bit of work in this field. So let's start with what is precision medicine and how does it benefit patients?
Sure. Precision medicine is about patients getting the right treatment at the right time. No one in this room is a hypothetical average patient. We're all different in meaningful ways, even down to our DNA. And what that means is that the way that we get diseases is going to differ. The progression is going to differ. Our response to therapeutics will differ. And while we have a system built on standard of care for the hypothetical average patient, we believe that one can greatly improve health outcomes and probably lower total healthcare costs in this country by $1 trillion. Out of the $4 trillion we spend a year in this country, there's probably a quarter of that is wasted because of not solving the matching problem well enough. So that is what precision medicine is, and it's not just about DNA sequence data. It's about the leveraging of all kinds of data that describes how each of us is different and how we respond to therapeutics differently. So in my mind, it is the basis of really the future of medicine and healthcare. And I hope and expect in the next 5 to 10 years, we won't be talking about precision medicine. We will take it for granted that that's what medicine is. That medicine is really practiced in a new way, driven by data, driven by AI, that matches the right drug to the right patient at the right time.
Right, and we'll be looking forward to seeing updates in that field. So now I'd like to open it up to you guys. Does anyone have any questions for our panel? I think I see one back there.
Hi, my name is John, and I'm from Anthem. And my question is about the precision medicine, and it wasn't brought up about anything about the privacy concerns. So how would you address that in precision medicine?
Maybe I'll start with that. So very carefully, GNS Healthcare, just like many other companies in the space, take patient privacy very seriously. Yes, we need the data. We need the data from patients in order to build these models and generate these insights. But we're not going to do that in a way that does risk any patient privacy issues. We do have HIPAA in this country, which we and everyone else take very seriously. But I think it's important to also realize there's a balance, right? There's a balance of if we go too far with the patient privacy such that it limits our access to data and puts too much of a tax on it, it can limit our ability to get the right treatments to the right people at the right time. And so we have to be pragmatic about these things, right? Because certainly when you have a cancer patient who is dying or close to death and they want that answer of which drug, which of these 15 different multiple myeloma drugs will work for me right now, you know, how important is patient privacy relative to answering that question? So it's a balance, in my opinion.
So do we have any others? Right. Okay.
Hi, Stacy Bridges. I'm with Veterans Vision. I'm an advocate for homeless veterans and veterans that suffer from PTSD and TBI, as well as a patient advocate. I know the future is going towards virtual medical care, but what if someone is suffering from adverse side effects from a drug? They could be suicidal or, God forbid, homicidal. What can you do to make sure that they are guided to the best treatment and there are facilities that are available to take them? How can you do that virtually?
Does anyone want to?
Yeah. I would just say that the VA has been actually one of the bright stars in terms of what's happening with virtual medicine, with telehealth, and as well as self-insured employers in terms of taking these technologies and using them to the benefit of populations. So in the case of behavioral health, which is really what you're touching on, what we've found is that providing these services virtually is as good, if not better, than face-to-face. And if you consider the fact that anywhere between 55 to 75% of counties in the U.S. do not have any sort of psychological services available or support, then building up these tools and resources, ensuring that there's sufficient broadband, doing what the VA did with partnerships with T-Mobile, for example, to ensure that data can be used, that's not counted against the plan. These are the kinds of things that are brought to bear to make sure that we reduce and mitigate the risk of people hurting themselves or hurting others. So I think it holds great promise, and the VA is really leading the field on that.
I would add to that, I think this is where relationship-based medicine is key. Trust is based on having longitudinal relationships with clinicians, where the clinician trusts you and you trust them. That can extend into the virtual world extremely well. But in my mind, the critical part there is to have the combination of the in-person care, where you can look people in the eye, establish trust, build a relationship, and then have that carry over virtually. I think it's a little hard to do that just virtually by itself. That's where we get a little bit worried about elements of trust and things become a little bit higher risk. But we're confident that if you have that in-person component, you're able to build that trust, build that relationship, and that it carries over quite nicely into the virtual realm.
Does anyone else have anything to add? I think we just have a little under a minute. If anyone has one more question. Oh, yes.
Hello?
Oh. There you go.
Hi, my name is Grace Collins, and I founded a company called Telecaregivers. It is focused on a new workforce development concept of starting people at the home health aide, family caregiver, to learn the techniques of the use of telemedicine apps, telemedicine applied products that you can attach to your phone, because everything is into self-tracking right now. Mm-hmm. So I want people to understand that we have 25 million college graduates that do not have jobs, but they're excellent with iPads, and they should be shepherded into the healthcare field, because there's going to be a big, big gap of people that do not have jobs, and especially at the home health care level. So I want to hope that the American Telemedicine Association would get to learn more about our project.
Absolutely. Well, thank you so much. I think we are just out of time, but yes, thank you everyone. Thank you to our panel, and thank you for your great questions. We appreciate it.